Hello, this is John Kanelopoulos. I'm presenting an interesting case. 35-year-old male. You can see here a perforating to the cornea injury with a tree branch. On corneal CT, you can see this went sideways and sliced quite deep in the cornea. Significant irregularity here on the pentacam maps. Topography steepened to the area that was perforated. 6 months later, vision has improved. The imaging looks better. You can see here there's some epithelium within this pocket created by the tree branch. The placido disc images have improved. You can see here the before and the 6 months later, as well as the pentacam mapping before and later. We discussed at the time the possibility of topographic guided PRK to improve and wait for a while to see if things changed. Here again, the changes on pentacam within the 6 months after injury. So 8 months after the second visit, 14 months after the original, you can see here that although the wound has improved, there's a significant pocket of ingrowth of epithelium within the cornea. You can see here the epithelial remodeling to compensate that. And there's this big epithelial cyst sitting within the traumatic pocket. The pentacam maps are, of course, unreliable due to the opacity. These are the Cassini maps showing the irregularity, and now the placido disc imaging is worse. There's a significant island there. So we're going to go to the OR and we're going to try and extract this epithelium. This is an exploratory case because we're not certain what the point of entry is. So this is the surgeon's view, and according to our OCT imaging, this is where the actual slice surfaced. So we're going to go in with a Blunsinski. Here we're removing some of the epithelium. We can see the clear cyst by ingrowth created within this traumatic pocket, but no point of entry. I will spend quite a bit of time here trying to find the area of injury, and again, this is 14 months after the original area of injury. Very few options here. Obviously, a PRK would improve the normalization of the cornea, but this epithelial cyst within the cornea created significant glare, and of course it has the potential to change, and with it the cornea parameters such as curvature, translucency, etc. So with the crescent blade here, we will create an opening to the pocket, just enough to enter with the Sinski hook and remove the epithelial cyst, which is done here. And following that careful epithelial removal, of course the visualization here with the epithelium off and the scarring is not optimal, but you can see here how deep this traumatic pocket was. It's quite large in diameter, over 2 millimeters in each meridian. Irrigating here with a LASIK spatula to remove as much as epithelium as possible. We can see here in retroillumination that the cornea transparency has improved, but there is still some epithelium sitting on the underside of the upper portion of the cornea of this pocket. So the actual side of the pocket will be amputated to create a flap. So convert this pocket to a flap and then try and remove the epithelium present under the pocket, which is now converted to a flap. So with the crescent blade coming in carefully and removing parts of that epithelial cyst, repositioned, and then irrigation. Of course, suturing here is a very difficult option as we're on the visual axis. If the epithelium does not regrow, I don't expect significant scarring, but I do expect significant irregularity, which we will attempt to correct with the topography guided normalization. A few options here. We will go ahead and use Resure bondage adhesive, which is a 2-compound. You can see here the bluest gel. The advantage of this compared to other glues I've worked with on the anterior segment is that it's very flexible. It kind of looks like a glued-on contact lens. And this seen here the next day with a very good results. And here another image of the Resure bandage adhesive, and the OCT image showing resolution of the cyst and the Resure adhesive on it. fortunately a good outcome for a very difficult case. I hope you found this interesting. Thank you very much for your attention. This is John Canelopoulos signing out.